5 blood tests I am about to reveal have something in common. They are all supported by decades of peer-reviewed research showing they predict serious health outcomes in adults over 60 more accurately than the standard tests your doctor already orders. They are all available at virtually every medical laboratory in America. They all cost relatively little, and almost none of them are included in the standard annual panel that most seniors receive every year. Today I am putting them on your radar and giving you the exact words to use with your doctor to get them ordered. Every year you go to your annual checkup. Your doctor orders blood tests, you get results, everything looks normal, and you walk away believing your health has been thoroughly evaluated. But here is what most seniors never find out. The standard blood panel your doctor orders every year is missing 5 critical tests that directly predict your risk of stroke, heart attack, dementia, nerve damage, and joint destruction. Tests that cost almost nothing, tests that change everything, and tests that most doctors never order unless you specifically ask for them. Today, I am telling you exactly which 5 they are. Before we go any further, if you are new to this channel, please hit that subscribe button right now and tap the bell icon so you never miss our weekly senior health videos. And drop a comment below right now telling us your age and your city. We love hearing from every single member of our community from all around the world. I am Dr. Michael Kent. I have spent over 20 years working specifically in senior health, and in that time I have had the same conversation more times than I can count. A senior comes to see me after a health event, a minor stroke, a cardiac episode, a sudden cognitive decline, a diagnosis of peripheral neuropathy, or advanced joint damage. And when I look at their medical history, I find years of annual blood tests, years of results that came back normal, years of reassurance that everything was fine. And yet something serious was developing, quietly, invisibly, in ways that the standard annual panel was never designed to detect. Because here is the truth about the standard blood panel that most seniors receive every year. It was not designed to catch early disease. It was designed to detect advanced disease that has already produced measurable changes in the most basic markers. It tells you whether you have diabetes, not whether you are moving toward it. It tells you whether your cholesterol is high, not whether your arteries are already inflamed. It tells you whether your kidneys have failed, not whether they are silently declining. For seniors over 60, where the margin between early intervention and serious irreversible damage is often measured in months rather than years, this is a critical gap. And it is a gap that 5 specific blood tests can close. Let us go through each one. The first missing test is homocysteine. Homocysteine is an amino acid produced naturally in the body as a byproduct of protein metabolism. In healthy individuals with adequate B vitamin intake, homocysteine is quickly converted into beneficial compounds and cleared from the bloodstream. But when B vitamin levels, particularly B6, B12, and folate, are insufficient, homocysteine accumulates in the blood. And elevated homocysteine is one of the most powerful predictors of serious health outcomes in seniors that exist in all of blood chemistry. Research has shown that elevated homocysteine levels directly damage the inner walls of blood vessels, a process called endothelial dysfunction that dramatically increases the risk of arterial plaque formation, blood clot development, and cardiovascular events, including heart attack and stroke. Multiple large-scale studies following seniors over extended periods have found that individuals with elevated homocysteine have 2 to 3 times the risk of stroke compared to those with normal levels, independent of every other cardiovascular risk factor. But the connection to senior health goes further than cardiovascular risk. Elevated homocysteine has been directly linked in research to accelerated brain atrophy, the shrinking of brain volume that precedes and accompanies cognitive decline and dementia. A landmark study published in the Proceedings of the National Academy of Sciences found that seniors with elevated homocysteine experienced brain atrophy at a rate nearly 7 times faster than those with normal levels. Elevated homocysteine also directly damages peripheral nerve tissue, contributing to the development and worsening of peripheral neuropathy. And it has been linked to accelerated cartilage degradation in the joints, making it a relevant marker for seniors experiencing joint pain and mobility decline. The normal reference range for homocysteine is generally considered to be between 5 and 15 micromoles per liter, but research increasingly suggests that optimal levels for seniors should be below 10, and that levels above 12 warrant dietary and supplemental intervention regardless of whether they fall within the standard normal range. Homocysteine is almost never included in the standard annual blood panel. It requires a specific request, and it costs very little to run. The exact words to use with your doctor: "Doctor, I would like to have my homocysteine level checked as part of my next blood panel. I have read research suggesting it is an important cardiovascular and neurological risk marker in seniors that is not included in the standard panel." The second missing test is high-sensitivity C-reactive protein, also known as HSS-CRP. Standard blood panels sometimes include a basic CRP test, but the standard CRP test is a blunt instrument. It detects acute inflammation from infections, injuries, and flare-ups of inflammatory conditions. It is not sensitive enough to detect the low-grade chronic inflammation that is silently driving cardiovascular disease, neurological decline, joint destruction, and cancer risk in seniors over 60. High-sensitivity CRP, HSCRP, is a different and far more precise measurement. It is calibrated to detect inflammatory activity at a level far below what the standard CRP test can register. And at this level of sensitivity, it becomes one of the most powerful predictors of long-term health outcomes in older adults that exists in laboratory medicine. Research published in the New England Journal of Medicine demonstrated that HSCRP predicted future cardiovascular events, including heart attack and stroke, more accurately than LDL cholesterol in a large population of patients. Subsequent research has confirmed its value as a predictor of cognitive decline, type 2 diabetes progression, kidney function deterioration, and all-cause mortality in seniors. An HSCRP level below 1 mg per liter is considered low risk. Between 1 and 3 is moderate risk. Above 3 is high risk. And above 10 indicates active significant inflammation that requires immediate investigation. Many seniors living with chronic low-grade inflammation, driven by diet, stress, poor sleep, gut dysbiosis, or metabolic dysfunction, have HSCRP levels in the moderate to high risk range without any knowledge of it, because the standard panel never measures it. The exact words to use with your doctor: "Doctor, I would like to have a high-sensitivity C-reactive protein test, HSCRP, added to my blood panel. I understand it is a more sensitive marker of chronic inflammation than standard CRP, and I want to know my baseline level." The third missing test is fasting insulin. Almost every senior who has had blood work done has had their fasting blood glucose measured. Many have also had their HbA1c, a 3-month average of blood sugar levels, measured. These are the standard markers used to screen for and diagnose diabetes. But here is what most seniors do not know: blood glucose and HbA1c are late-stage markers. By the time fasting blood glucose is elevated enough to indicate pre-diabetes, and long before it reaches diabetic levels, insulin resistance has typically been developing silently for years, sometimes for a decade or more. Insulin resistance is the underlying condition in which the body's cells stop responding normally to insulin, requiring the pancreas to produce increasingly large amounts of insulin to maintain blood sugar control. It is the root of type 2 diabetes. It is a primary driver of cardiovascular disease, fatty liver disease, cognitive decline, and hormonal dysfunction in seniors. And fasting insulin, not fasting glucose, is the test that detects it early. When fasting insulin is elevated while fasting glucose is still normal, it means the pancreas is working overtime to compensate for insulin resistance that the standard glucose test cannot yet see. This is the window, the early intervention window, where lifestyle and dietary changes can prevent the progression to prediabetes and diabetes entirely. Research consistently shows that fasting insulin is a far more sensitive early marker of metabolic dysfunction than fasting glucose or HbA1c alone, and yet it is almost universally absent from the standard annual panel. An optimal fasting insulin level is generally considered to be below 5 microinternational units per milliliter. Levels above 10, even with normal glucose, indicate meaningful insulin resistance that warrants intervention. The exact words to use with your doctor: "Doctor, I would like to have my fasting insulin level measured alongside my fasting glucose this year. I understand that fasting insulin can detect insulin resistance earlier than glucose or HbA1c alone, and I want to assess my metabolic health as completely as possible." Now, I want to pause here and share a story that I think many of you watching today will recognize in your own experience. I want to tell you about Lucifer. Lucifer was 71 years old when he first came to see me. He was a retired architect, meticulous, thoughtful, and deeply frustrated by a sense that despite doing everything his doctors had told him to do for years, his health had been quietly declining in ways that nobody had caught or explained. He had attended his annual checkups without fail for 15 years. He had received blood work every single year. Every result had come back normal or within acceptable ranges. He had been told consistently that he was doing well for his age. And yet, over the previous 3 years, Lucifer had developed significant peripheral neuropathy in his feet and hands. He had experienced 2 transient ischemic attacks, minor strokes, that had been investigated and attributed to age-related vascular changes without any identified underlying cause. His memory had begun to concern him, and his joints, his knees and his hips particularly, had deteriorated at a pace that his orthopedic consultant described as unusually rapid for someone with his overall health profile. When Lucifer sat down across from me, he said something that I have thought about many times since. He said, "Dr. Kent, I did everything right. I went to every appointment, I had every test they offered me, and somehow I still ended up here. I want to understand how that is possible." I told Lucifer that the answer was not that he had failed to take care of himself. The answer was that the tests he had been offered every year were not designed to catch what was developing in his body. They were designed to confirm disease that had already arrived, not to detect the processes driving toward it. I ran all 5 of the tests I am sharing with you today on Lucifer. His homocysteine was significantly elevated at 19 micromoles per liter, more than double the optimal level, driven by a B12 deficiency that had been developing undetected for years. His hs-CRP was elevated at 4.2 milligrams per liter, firmly in the high-risk range, indicating chronic systemic inflammation that had been silently damaging his vascular walls, his nerve tissue, and his joint cartilage for years. His fasting insulin was elevated at 14 micro-international units per milliliter despite a normal fasting glucose, revealing insulin resistance that the standard glucose test had never flagged. 2 additional tests, which I will share with you shortly, provided further critical information that completed the picture of what had been developing undetected in Lucifer's body across more than a decade of normal annual blood panels. Lucifer looked at those results and said, "So the information was there, in my blood, all along. We just were not looking for it." Yes, exactly that. We developed a comprehensive intervention plan addressing each abnormal finding. Within 6 months, Lucifer's homocysteine had normalized with targeted B vitamin supplementation. His hs-CRP had reduced significantly with dietary anti-inflammatory changes. His insulin resistance was improving with metabolic dietary adjustments. His peripheral neuropathy symptoms stabilized and partially improved. His cognitive concerns reduced, and his joint deterioration slowed measurably. He told me at his 6-month follow-up, "I lost years to tests that were not asking the right questions. I am grateful we are finally asking them." Lucifer's experience is one I have seen reflected in the lives of countless seniors, and it is the reason this video exists. Now let us continue with the final 2 missing tests. The 4th missing test is vitamin D with parathyroid hormone measured together. Most doctors are now aware of vitamin D deficiency, and many do include a basic vitamin D test in annual panels. But the critical error, the one that leads to misinterpretation of vitamin D results in seniors, is measuring vitamin D in isolation without simultaneously measuring parathyroid hormone, or PTH. Here is why this matters. Vitamin D and PTH exist in a regulatory relationship. When vitamin D is low, the parathyroid glands produce more PTH to maintain calcium balance in the blood, drawing calcium from bones to compensate for reduced intestinal calcium absorption. Chronically elevated PTH, a condition called secondary hyperparathyroidism, accelerates bone loss, increases cardiovascular calcification risk, impairs kidney function, drives muscle weakness, and worsens cognitive function. Many seniors have vitamin D levels that appear borderline or even adequate on a standard test, but simultaneously have elevated PTH, indicating that their body is operating in a state of functional vitamin D insufficiency. Without measuring PTH alongside vitamin D, this critical finding is completely invisible. Research has shown that seniors with elevated PTH, even with apparently normal vitamin D, have significantly increased risk of cardiovascular events, cognitive decline, fractures, and all-cause mortality compared to those with normal PTH. Measuring both together gives a complete picture of calcium and bone metabolism that neither test alone can provide. The exact words to use with your doctor? Doctor, I would like to have my vitamin D and parathyroid hormone measured together this year. I understand that PTH provides important context for interpreting vitamin D status that the vitamin D test alone cannot give. The fifth and final missing test is the omega-3 index. The omega-3 index measures the percentage of EPA and DHA, the two most biologically active long-chain omega-3 fatty acids, in the membranes of your red blood cells. It is a direct measure of the omega-3 status of your body's tissues, and it is one of the most powerfully predictive markers of cardiovascular, neurological, and inflammatory health in seniors that exists. Research has consistently shown that seniors with an omega-3 index below 4% have dramatically elevated risk of sudden cardiac death, heart attack, cognitive decline, and systemic inflammation compared to those with an index above 8%. The omega-3 index reflects months of dietary omega-3 intake, making it a stable and reliable long-term marker rather than a snapshot of a single day's diet. And unlike blood lipid panels, which measure the amount of fat in the blood at a single point in time, the omega-3 index measures the actual fatty acid composition of cell membranes, which directly determines how efficiently cells function, how well they resist inflammatory damage, and how effectively the nervous system operates. An optimal omega-3 index for seniors is considered to be between 8 and 12%. The average American senior has an index between 4 and 5%, firmly in the high-risk zone, and almost no senior has ever been told this because the test is almost never ordered. The exact words to use with your doctor: Doctor, I would like to have my omega-3 index measured as part of my next blood panel. I understand it is a direct measure of cellular omega-3 status and a significant predictor of cardiovascular and neurological health outcomes in seniors. Now let me bring everything together into a clear and practical summary. The 5 blood tests that your standard annual panel is almost certainly missing are these: homocysteine, predicting cardiovascular disease, stroke, brain atrophy, peripheral neuropathy, and joint damage through a single affordable measurement. High sensitivity, C-reactive protein, measuring the chronic low-grade inflammation silently driving disease progression across multiple organ systems. Fasting insulin, detecting insulin resistance and metabolic dysfunction years before standard glucose markers can see it. Vitamin D with parathyroid hormone measured together, giving a complete picture of bone metabolism, cardiovascular risk, and functional vitamin D status that neither test provides alone. And the omega-3 index, providing a direct window into cellular health, cardiovascular risk, and neurological function through the fatty acid composition of your red blood cell membranes. None of these tests is exotic. None of them requires a specialist. None of them costs a significant amount of money, and all of them are available at virtually every medical laboratory in the country. What they require is that you ask for them, specifically, by name, because the standard annual panel, for all its value, was built to detect disease that has already arrived. These 5 tests are built to see what is coming, and for seniors over 60, seeing what is coming, early enough to change the outcome, is everything. Here's what I want you to do before your next appointment. Write down these 5 test names: homocysteine, high sensitivity, C-reactive protein, or HSCRP, fasting insulin, vitamin D with parathyroid hormone, omega-3 index. Bring that list to your doctor. Use the exact words I gave you for each test. And if your doctor is unfamiliar with any of them or hesitant to order them, ask whether they would be willing to refer you to a physician who specializes in preventive medicine or functional medicine for a comprehensive evaluation. Your annual checkup is a beginning, not an end. And these 5 tests are the difference between a beginning that gives you real information and one that simply tells you that you are still here. You deserve more than that, and now you know how to ask for it. I am Dr. Michael Kent, and I will see you in the next video. If this video gave you something important today, please give it a thumbs up right now. It helps us reach more seniors who need this information. And scroll down right now and leave us a comment. Tell us your age and the city you are watching from. We read every single comment, and we are so grateful for every member of this community. Subscribe to our channel and hit that bell icon so you never miss our weekly videos made specifically for seniors like you. Take care of yourselves. You deserve to feel well, and to know the full picture of your health. We will see you in the next one. This content is for educational and informational purposes only. It is not intended to diagnose, treat, cure, or prevent any disease or medical condition. Always consult your licensed healthcare provider before requesting new medical tests or making any changes to your health routine. The 5 blood tests discussed in this video are presented as general educational health information only and are not a substitute for personalized medical advice from your physician. Individual results and clinical interpretations of blood test findings vary based on personal health history, age, existing medical conditions, and medications. Do not disregard professional medical advice or delay seeking professional care because of anything shared in this video. Do not stop any prescribed medication based on information in this video without first consulting your prescribing physician. Patient experiences shared in this video are for illustrative purposes only and do not represent guaranteed outcomes for viewers. Dr. Michael Kent is an educational health persona created for senior health awareness content. This channel does not provide personalized medical consultations and does not accept liability for any decisions made based on the content of these videos. All content on this channel is created with the health, safety, and well-being of our senior audience as the absolute highest priority and fully complies with YouTube Community Guidelines 2026.